Welcome to the NSCHBC Edge Podcast, leading the way in the business of medicine. Now here's your host, Terry Fletcher.
Hello, everyone, and welcome to the NSCHBC Edge Podcast. I'm your host, Terry Fletcher. The Edge Podcast is brought to you today by the National Society of Certified Healthcare Business Consultants. Our goal is to discuss healthy business principles, have conversations on the business side of medicine, so that you and your practice can thrive, be profitable, and successful for years to come. Which leads me into our podcast topic today. As many of you know, the NSCHBC is a proactive organization with over 300 members, including legacy members that share their wealth of knowledge and expertise with each other, whether it be in the legal field, the accounting field, the revenue cycle management field, the business management field, or even value-based care field, and more. We have every kind of consultant that focuses on the healthcare industry that you could possibly want. So today I'm very excited to have my good friend and healthcare consultant and educator, Christine Hall of Sterling Global Solutions. And Christine, welcome to the program. I'm so happy to have you on the Edge Podcast today.
Thanks, Terry. It's a pleasure to be here. I love the topic that we're going to challenge today.
Me too. And just so everyone knows, Christine and I are, I'm going to just say it, we are telehealth gurus. That is what our title is known in the podcast world. So we've been both educating and talking about telehealth, auditing on telehealth. Now that's a big deal. And not just educating, but also training on it and explaining. But then the pandemic hit and everything we knew about telehealth kind of went by the wayside because of all the flexibilities. And then we had the extensions. And it's one thing if during a public health emergency where they say, okay, for a couple of weeks, this is what we're going to do. But when it turns into 3.5 years, we have problems because now people are like, oh, this is great. Let's expand our business. Let's put the expense in this, or let's start doing things that we think we can do forever, even when there is no more public health emergency or virtual care may not be appropriate. And as our last HHS, director said, where I think it was even a Medicare administrator, you can't put the genie back in the bottle.
Yeah.
Well, some of it is put back in the bottle and some of it isn't going into 2024. And that's what Christine and I are here to talk about today. Not in education webinar form, but we just want to have a conversation with our listeners about telehealth 2024, what's really appropriate, what should be on your radar as far as, exposure for your practice if you're inviting risk, and then where the positives are. So Christine, with that, I'm going to kind of open it up to you on a couple of things that are now really part of the 2024 rules. So a couple things that have come up, and this is something everyone has to know. So before January 2024, as of right now, you are to be using the place of service either O2 for a patient's not in their home, and a place of service 10 when a patient is in their home. And O2 is actually going to reimburse at facility rates, and place of service 10 will reimburse as if you're in person. But what they do in 2023, or what we did, was that you were supposed to use the place of service where the patient would have been had they reported in person, which became a mess. So Christine, I'll let you take the place of service conversation. What do you think about the new change, which I like? I'm glad it's different now.
Here's the thing, Terry. I think we've got to also remember that the most guidance that comes out is from CMS. They're pretty straightforward. They release it timely. And if you're active on social media like LinkedIn, you're going to see that everyone's pretty comfortable sharing that information that comes from CMS. But remember that a lot of the individual payers might also have separate rules. And recently I was working on an audit, and I noticed that the commercial payers maybe didn't adopt some of the same rulings that CMS did when it came to how we report those visits. So even during the public health emergency, there was a really long list of, okay, for this payer, we do this, and for another payer, we do that. I wish that payers would fall in line with one overall consensus of guidance, maybe following what CMS puts out there. But that is true what you were saying. So through the public health emergency, we were advised by CMS to report the place of service that we would have normally seen the patient and apply the modifier 95. And what that did was it made sure that professional service providers or fee for service providers, that they were getting reimbursed at maybe that non-facility rate that they're usually reimbursed at, rather than the facility rate, which was lesser, which telehealth was falling underneath. We were reimbursing at that. So they said, now that we're out of the public health emergency and we've gone through all of our extensions, moving forward into 2024, CMS will continue to pay for services via telehealth, but they're going to adjust that payment accordingly, whether the patient was seen in their home or whether the patient was seen in an originating site. So that originating site will continue to receive that reimbursement for utilizing that site that the patient is located at.
Right, which is usually, if it's not in their home, they're saying it's probably going to be in the hospital or
Or
elsewhere.
an office.
They don't want the doctors to get dinged for the patient being in their home, but they said that, there is usually around a 20% reduction or facility rates. What I find interesting is what you were saying about the commercial plans, and this is interesting for the listeners to really know. I have heard from several commercial plans, and Christine and I educate for payers as well. I audit for payers. And one of the things that I heard is that they resisted offering telehealth to what the expansion that Medicare did internally. But they knew that if they didn't come up with a plan in 2020, they were going to be forced to, either by HHS or, some kind of executive order, which some states did. And so basically, like, well, let's be proactive and let's do it. But as soon as they realized that, the country was opening up again, in early 2021, and vaccines and all that, they were like, okay, we're not doing this part anymore, or we're not doing this anymore. We're
Right.
changing our coverages. So it was really important for practices to be proactive and know what commercial plans were doing. I think what was helpful on the Medicare and Medicaid was very strict, but both of the government side is that we always had a black and white roadmap. So we had, white paper instructions. Sean Weiss, a good friend of Christine's and mine, who's also part of the NSCHBC, and we're on his the Compliance Guy Roundtable podcast. He had asked me, he was doing an audit. He said, hey, I can't find the original guidance from Medicare way back in March 1st of the telehealth flexibilities. And I had it. He goes, can you email me it? It was only 30 pages.
Right.
And now what is it? 230 now it's like at least 185. I knew it's up there in the couple hundred. And so instead of, they revised some things, but they started dating each entry now at the bottom, like when it became effective, so that we knew the timeline. And what's interesting as far as all the coverages and all the changes, all the flexibilities, when OIG comes in to audit, and let's say they get help, like from someone like us, I have to put out my timeline. I'm like, okay, the doctor did this, and this was okay from this date to this date.
Right.
And then the doctor did this, or then the physical therapy did this. And there's certain dates where certain things weren't appropriate and certain things were. And you have to have this huge timeline of when you can, say, well, they were right here, or, this wasn't appropriate.
Right.
And, just kind of going in a different direction off the topic. One thing that still, I think this is going to be the bane of our existence, is audio only phone calls. So the 99441 to 443 codes that are in the CPT right now, they're going to be deleted in January of 2025. But I think, I know people are using them inappropriately. They are, and you had brought up, before we started, that CPT 2024 was so insightful in letting us know when those codes are appropriate, and they have to be similar to the in-person codes or audio and video codes. It's just when a patient isn't able to do audio and video. And I think doctors and practices and other providers who qualify for virtual, they're taking liberties with these codes. They're saying, oh, well, I'm calling for, test results, or I'm letting the patient know I refilled their prescription, or I'm scheduling a audio only. No, you can't do that.
We have to remember, it's an evaluation and management.
It's
It's not a chat. It
Right.
is to say, hey, here is a problem. We're evaluating that problem and we're coming up with the best way to manage it during this interaction. And not all interactions should be done over the phone.
Well, how many providers do you have or clients that are saying that I'm calling to check in on patients, so I'm charging a phone call? No, you
Absolutely not.
you can't do that. These are supposed to be, and actually Medicare put out some guidance, CMS did. They
Hmm.
put out some guidance last, I think it was April, and then it was in the final rule, and it said that you have to document when the patient, why the patient had to have an audio only versus an audio and video, which I was
Right.
like, okay, now at least they're speaking, saying, they're saying, this is the last resort. This is, has to be a replacement E&M service. It's not to check in. It's not to give test results.
Right.
Here's something, Christine. So I was talking to a few coders about this, and I keep using the phrase, well, prior to the pandemic, and one of the coders, and this is my fault totally, she goes, well, actually, I didn't get my job until 2021. And I just went, oh, shoot.
Okay.
So she's like, I don't know what the rules were prior to the pandemic. And I have to be mindful of that when realizing the pandemic, again, was 3.5 years, and some people didn't
Yeah.
even start in healthcare until, 2 years ago or 3 years ago.
But
So,
I think it's important though, Terry, that we share with our listeners that, while we talk about the growth that we've seen. Now, during the public health emergency, just go back in time and think about we had a lockdown. We advised people not to leave their homes if they were immunocompromised. We asked them to please, you know, stay indoors to help prevent the spread of COVID. Well, that doesn't exist anymore. So, like you said, prior to COVID, would you have gone to the office for a routine visit? Yeah, then you should be going to the office for a routine visit now. Maybe there we should have some criterias in place, or we should encourage listeners to put policies in place of when is it really appropriate to have that telephone visit or even that audio video visit that's not a telemental health visit, right? Maybe just a regular visit. When is it appropriate? Is it acute things? And what acute things? Like a broken ankle? That's not really something you can do via telehealth. Um,
right.
have some criteria in place that if you maybe you speak with your providers, your physicians, and you say what would be the right criteria and put that into play now that we are outside of the public health emergency. We're trying to get back to somewhat of normalcy. We want to keep telehealth. We don't want it to go away.
Right.
But in the same sense, we got to find some way to make sure that there's some accountability there, that we're doing it for the the reasons that CPT, CMS feel that is appropriate.
Well, remember there's also the what is it? The C2C. Is that care to care? Is that the Medicare?
Yeah.
They put
Yeah.
out this I don't even know what it is. Every once in a while I stumble across it. But C2C, and that's cat two, number two, cat, care to care. It's this document that HHS and CMS put out, and they actually have within this document, and it's weird how they put it. They what is most likely appropriate for telehealth and what is most unlikely appropriate. I wish they'd be like, this is not telehealth and this is, but it's more of a this is what you'd have to support. And if you're doing telehealth on where it's not likely, then you might have to also defend. And Christine and I are on offense. We want you to make sure that your claims are clean, that if you ever get questioned or they say send records, you're like, sure, what records do you want? Not you're like, well, let me look first. Wait, let me just check before. It's like somebody stopping by going, one of your friends, hey, can I use your restroom? No, give me a second. I
I
always look
need to
at that. I know
go.
it's a bad analogy, but I tell my daughter that because I'm like, your house is clean when somebody stops by and can I use your bathroom? You're like, sure. I'm like, it's the same thing to me and,
Absolutely.
and opening records. It's like, yeah, no problem. And this is such a bad analogy. I'm going to get cards and letters. But when I think about, what they said in that C2C, and I use it in a lot of my telehealth
Hmm.
webinars, they were talking about physical therapy was a big one. And you and I talked about this before.
Yeah.
And it seems like just because you can doesn't mean you should. And so, patients don't always want their their spouse or their caregiver to have to be the acting physician or therapist or, clinician. They want the actual person they trust to know if they're improving or declining or progressing or degressing or decompensating. And I had a neurologist tell me a story, and he goes, telehealth is great. And just so you know, Christine and I are proponents of it. We think it
Oh
definitely has a
yeah.
place in the delivery of medicine. I know it doesn't sound like it, but it does. But I had a neurologist saying, I had a patient, we did 6 months of care, which is all telehealth and audio and video. And the one patient, she didn't want to do one day where it was audio only. And he's like, I really wanted to see her. He's like, and then after that, he goes, I need to see you in person. And when the last time he saw her in person, she had just the beginning stages of Parkinson's. And she was like, oh no, I'm doing better. But he said on the video, he could she was always in a chair, sitting upright, or she was on the edge of a couch or whatever. And he really couldn't see what he needed to see from a neurological standpoint. So she comes into the office. She could barely get to the chair. When she got up off the chair, she almost fell. He said he feels like there was kind of a definite decompensation from not being seen in person. And
Well,
that
Terry,
scares me. That's just really
I
scares me.
I'm just as guilty. I'm not going to lie. I have a connective tissue disorder, so I do a lot of physical therapy, and physical therapy via telehealth. I lie. Oh yeah, I'm making that range of motion. Oh yeah, I did 20 reps of that. I
You're a
lie.
bad patient.
I am a very bad patient. I need that accountability of being in the office. I need that therapist there checking to make sure I've done the extension correctly, that I've completed the reps there. Um, I think that we do need to reevaluate that. And like you said, I love telehealth. I love it. I tell the story all the time. My big 6'2" husband had a total knee replacement, and 3 days after surgery, they wanted him to come in for a check-in. So we take this giant man and we shove him in a car and we put him in an elevator and we take him up there, and the doctor comes in for 2 seconds, looks down at the wound and says, "That looks great. I'll see you in 2 weeks." That could have been a telehealth visit,
It could
really.
have been,
And
yeah.
or would you pick your kids up after school and one of them has coughing and wheezing and maybe a little fever, and the urgent care is not open. Telehealth is perfect for those types of scenarios. Um, but there's other areas that telehealth is not. Like I said, if I fracture my ankle, you can't help me via telehealth, right? So
Well, and
there's a time and place.
my father-in-law had an issue a couple years ago now that he's passed. And I've mentioned this before, I think on a past webinar, but he had a rash and it was right at the height of the pandemic. He was 90, 91. And they kept giving him topical ointment. They said he couldn't come in because it was like March or April of 2020. And they did this for like 4 months. Well, when he finally was able to be seen, and we weren't actually not really allowed to see him either because, obviously they're like,
Yeah.
hey, people can't go anywhere or whatever. And finally, I'm telling my husband, I'm like, we need to go see dad. We need to go see your dad and we need to see what's going on. And since, I have a nursing background, he's like, okay. He goes, but it's in an area. He's going to be embarrassed. I'm like, tell him, no, just let me look. So I looked and I'm like, we need to get him in. It was a palpable mass. Turned out 6 months after the first look at it on over telehealth, it was Hodgkin's lymphoma.
Oh my
It was stage
gosh.
4 and it was now inoperable. And the doctor said, yeah,
Oh,
4 months ago we might have been able to do something, but now we can't. And so
no.
it scares me. And he passed away 3 months after that. And it really makes me nervous when I see things like potential cancer things or,
Yeah.
even going to the physical therapist. My husband's brother, he had a rare condition of something a few years back and he needed extensive PT. And
Hmm.
then the pandemic hit, and they're like, okay, so we need your wife to come in. And his wife has rheumatoid arthritis. And she's like, my wife is not my therapist. You are, and I want to schedule an appointment. Well, we're only now doing virtual. And I'm like, what? I didn't even think that was allowed, Christine. I thought you had to at least offer in person, and I know Medicaid doesn't allow it. They're
Right.
like, no, you have to offer. If the patient asks for it, you have to offer it. And I think I read something Medicare
Absolutely.
too, but
Yeah, yeah.
it bothers me when the default is virtual versus it's an option for delivery of care. So default should be in person like it always has been. And then if there's a circumstance where it's necessary to, the patient maybe is out of town or the patient is just not physically up to coming in, maybe those are the appropriate, virtual
Hmm.
telehealth opportunities or even well checks, not what we were talking about because physical therapy yearly, those aren't covered under telehealth,
Right.
but only annual well checks are. That's totally different, doesn't involve an exam. But
Preventive medicine,
yeah,
yes. Hmm.
preventative medicine visit that you see in the CPT
Yeah,
book, those are
not
not
covered.
telehealth. Yeah, just annual well visits, which are just have you ever had, are you using your seatbelt, risk factor reductions.
Right.
Um, but it's interesting to me when I see telehealth being, and I hate to say pushed on patients, but telling them that's their only option instead of really trying to make that connection and
It's
that
so crazy,
physical
Terry.
in person.
We before the public health emergency, I mean, you and I have been in telehealth for a long time. I fell in love with telehealth when I was watching the Jetsons on Saturday morning cartoons. But I
We
did
just
really,
aged ourselves.
I
Everybody's like, "Who
know.
are the Jetsons?" I'm like, "Oh no, that's so funny."
Check it out on Cartoon Network. Anyway, but well, and I would talk to providers even before the public health emergency to say, hey, there are certain circumstances where you could utilize telehealth services with your patients. Maybe those patients that are not able to come in for a face-to-face visit, or if you had an after hours, maybe, there are certain circumstances. And I did not get as much interest in telehealth
I
prior
got
to the
pushback.
PHE.
Yeah,
Right.
I couldn't get them to buy into it. And in like 2017, 18, I'm like, but you've got to practice that this would be great. Primary care, you've got pink eye,
Yeah.
kids or, you can see that over the video. No, they really need to come in. I'm like, oh my gosh, it's so contagious. And medicine checks where patients are
Yeah.
chronic conditions, they need to get refills, but it's not preventative, it's more chronic, stable, but let's check and see what's going on. Yeah, those kinds of things perfect for telehealth. But
Absolutely. And now we're getting into the PHE happened, and now you've got practices that like you were just saying, no, 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 we only do virtual. Well, how did we get from I'm not comfortable with virtual to everything is virtual in such a short period of time and not think about those concerns that were there just a few years ago? They
well,
didn't go away.
I think the one thing that I believe that HHS and CMS thought was going to happen is that virtual care was going to lessen the expense of medicine because you don't have to have a full-time brick and mortar office. You can get rid of some staff because the doctors can handle, just coming into a virtual room. They can do things, differently. And I'm seeing that it's increasing some of that expense because it's in
Hmm.
addition to, it's not instead of. And it's driving me a little bit nuts because I'm just seeing it be abused a little bit. And I'm a little concerned with, practices and providers that aren't utilizing it and understanding it's not a separate specialty. It's an
Yeah.
additional delivery of medicine and it's absolutely necessary. We have patients that absolutely can use telehealth and again, I think the most the provider I think uses it the most in one of my clients is a oncologist. And not everyone is telehealth, but when he does provide certain services, going over their whole
Yeah.
MRIs and their CTs and saying, okay, this is what we're going to do for radiation, this is what we're going to do for chemo
Right.
after the patient's already had the cancer surgery and gone through the some of the protocols for post-op. To me, that's absolutely appropriate.
Yeah.
That's more you're in the comfort of your home, let's have a conversation. But when I see these incidental just because I can, it just makes me sad because like you said, there's such a need for it, there's a time for it.
Hmm.
But if you're going to abuse it and not use it when it's appropriate and reflect that it's a part of your practice instead of it's only your practice, I have some doctors who haven't even come back from their home where they were seeing
Yeah.
patients in their home, and they're, or not, they're seeing them virtually from their home, I should say.
Right, right.
And I don't know why CMS extended the virtual supervision to through 2024. They didn't at first. They said it was done at the end of the pandemic, and then they said, well, 2023, and then people complained and they said 2024. But I don't understand why they did that, because it doesn't make sense to me. And
Direct supervision.
well, that's weird. I
Yeah,
mean, direct supervision means that you have to be immediately available. How are you immediately available if you're on an iPad or if you're on a computer? What
it
if you
doesn't make
have a
sense
patient
to
that,
me.
yeah, what if you have a patient that codes out and you've got to, and you got to call 911? I had an urgent care ask me how to do telehealth virtually for their urgent care needs. I'm like, I gotta go now. This
Oh
is
my
not a phone call I
gosh.
want. I always laugh at my
Oh.
one call I had that I think was probably the best one, that the acupuncturist in 2020 that called me, and I'm glad I never got that after that.
Oh my
I
gosh.
was like, you're better than me. I think I'm a pretty smart person, but if you can tell me how to do telehealth for an acupuncturist, then,
Oh my
knock
gosh.
yourself out. But I can't see that, teaching somebody to dry needle somebody. I don't think so.
Mm-mm.
But
No.
I just get nervous. And now I heard some. Oh, you'll like
Well,
this. I heard
I
something.
think I wanted to bounce right back to
Sure.
the direct supervision for just a second. And I think we need to make that distinction. There's a couple of things out there. So direct supervision could be for the ancillary staff, could be for, maybe you have the medical assistant or phlebotomist who draws blood in your office. And what if something goes wrong? The whole purpose of that direct supervision is if the patient starts to bleed out, maybe the phlebotomist didn't know they were on Coumadin, or undiagnosed leukemia or something like that. To have that physician in the office to provide that immediate intervention is critical. And to take advantage of that by saying, well, we'll just have them on the phone available when they're in the operating room, or when they're on vacation, or when they're whatever that case may be, it almost feels a little irresponsible. And do the malpractice insurances know that these practices are utilizing that virtual direct supervision for ancillary staff? That's just being devil's advocate, like
No, I
saying,
agree.
think about how bad it could go. Not that we ever want to, but the old saying, prepare for the worst, right?
Yeah.
And
Now
hope for the best.
you've seen it for residents, and I think sometimes that can be a good thing. So when they're virtually supervising residents who are seeing patients, I think because of staff shortages, I'm seeing that more
Yeah.
and more. And people are trying to see as many patients as they can, but you can't be in two places at once, and so they're in multiple hospitals, and they're like, okay, I got to check in with the residents who have to be supervised in like teaching facilities and things like that.
Hmm.
I think that's actually probably a good thing on the
Yeah.
the virtual supervision, as long as it's not abused and you are in person checking in on occasion. But when I see it just routinely applied, I think that's what you and I are talking about.
Yeah.
The other thing, and I'm just going to pivot to crossing state lines. Oh boy. Oh my goodness. So this is another thing that I think a lot of the states didn't want to have mandates. So they said, okay, we'll buy in. What we're talking about is you're a physician that's in New York, and your patient now went, we call them snowbirds. They went down to Florida, and yeah, where Christine is located, and I'm in California, so we're very good friends from across the country. But they go down to Florida, and they're there 6 months out of the year or so, and so a lot of their doctors who are up north, New Jersey, New York, they're seeing them virtually, which again, during the pandemic, that was fine until it wasn't fine, and you had to look at state rules. And Florida was one of the first in 2021. They're like, okay, we want our fees back. So unless you're licensed here,
Right.
and you're not part of I think it's called a co-op, or
It's
it's
the
a
interstate compact.
compact, interstate
And Florida
compact.
doesn't participate in
No,
the
neither does
interstate
California.
compact.
Neither does
Hmm.
California.
That's right.
And so, if you're not part of that, which means you can cross lines and be licensed in other states because you have a central license, then you could be treating without a license. But it's where the patient is located at the time of the virtual encounter, and where the physician is located and where they are licensed at that time. So if the patient's in Florida, the doctor would have to be licensed there. If the doctor's in New York, they have to be licensed there. But let's say the doctor's on vacation and they are still going to see a patient just real quick, and they are in North Carolina and the patient's in Florida. They would still have to be licensed in North Carolina.
Yeah.
And here's something that Reed told us. He's one of our executive members, Reed Tinsley at the NSCHBC. He just put it out there, one of our education committee meetings. He goes, yeah, now there's tax implications. I'm like, to what?
Oh, yes, I heard about
didn't
that.
know about that, Christine.
Yes,
He's like,
yes,
yeah,
they
if
were
you see a
making money
patient,
in other
yeah,
states.
if you make money in other states, it's kind of like a professional sporting team. You know, if you have a golf tournament in this state that has taxes, but you live in a state that doesn't, you still have to pay the taxes on where you did it. You know, that's why I heard UFC fighting doesn't have, contests here in California because our taxes suck here. So they're like, no, we don't go to California. It's not worth it to anybody. We go to, either, we go to Nevada or we go to Dubai. We go out of country. But it's interesting because what Medicare did, and I think this is terrible, is that they kind of gave the impression at the height of the pandemic and even through 2021 that you could see any patient you want anywhere they were in the country. And then all of a sudden in 2022, in April, they came out with a one-time published guidance that said, well, not so fast. If the states didn't say you could, anything we say doesn't really count. The states have to say it as well. So it's states jurisdiction. And I had a lot of doctors, all of a sudden, a lot of clients going, hey, you told me to look at the state and you sent me the information, but we didn't because we saw on TV that the president at the time, whether it be who we have now or who we had before, had said we could do it. And then HHS or CMS said we could do it, but they never said we could. And now our malpractice is questioning what we did after it went back.
It's not only that, Terry, is that people saw, again, like the president or CMS make a comment and assumed that all payers were following this guidance.
Right.
And that is still to this day not the case, where you have to remember that we have our federal payers, our government payers, and we have our private payers. And that's the uniqueness of our healthcare system, is that we have a nice mixture of both. But those private payers, those commercial payers, they're not covered by any of the federal guidelines that come out. They have their own proprietary guidelines.
Yeah, and they have to look at payment or policies. You have to be on top of this as well. And every payer is different. Unfortunately, there's not basically a commercial plan. It's everybody has a different conversation about that. I saw something in a different policy. I saw something in United Healthcare that said you had to be in a clean space and you couldn't be in your car. Well, I had patients that were driving to Starbucks because they offer free Wi-Fi and sitting in the parking lot to get their virtual care because they didn't have, high-speed internet at home. And United Healthcare is like, well, we don't do that. So I'm just like, wow.
Well, another thing to remember, Terry, talking about payers, I recently finished a Cigna audit, and Cigna has a policy that you must be using a HIPAA compliant platform to provide telehealth services or audio only services, which they don't really cover audio only in this particular audit that I was reviewing. However, a lot of people don't realize that the Office of Civil Rights never said you could use applications. They said, here's what we'll do. Is while you're getting a HIPAA compliant software in place, we know that, the pandemic, you're not fully ready. We're just going to turn a blind eye and hope that you're using a forward-facing application until you get your HIPAA compliant application in place. Not that you were going to be able to use FaceTime indefinitely. And I still see providers to this very day that didn't get that message and are still using FaceTime to do telehealth services with their patients.
Yeah,
those aren't reimbursable.
No, and Skype and Google Hangouts. And remember, people said, well, I use Zoom. And I said, okay, so Zoom, like what Christine and I are, recording on for our podcast, that we could be Zoom bombed at any time. This is not HIPAA compliant.
Oh, I've had that happen.
Me too.
But how awkward is that?
You have to have Zoom for healthcare, Remember,
Right.
if it is an app or if it is a platform that you don't pay for, it's probably not HIPAA compliant. And the Office of Civil Rights, the OCR, came out and said that they gave a 90-day extension after the end of the public health emergency, and everyone had to have HIPAA compliance in their platforms for delivery of telehealth by August 9th of 2023. So we've had, like Christine said, we've had a lot of people saying, well, I didn't know. That's not an excuse.
Right.
This has been on every possible social media. This has been on every possible published guidance. It is your responsibility to not only take your educational webinars that we put out. I think, Christine, what do we teach one almost once a month, it seems like?
Yep.
All the time. Look at the NSCHBC website. We always have them. Look at Christine's and my own website, terryfletcher.net. What's your website?
Sterling Global Solutions, STIRLING Global Solutions.
Yeah.
But Terry, I wanted to remind everyone, one of the things that I get a lot is, how do you stay on top of all of this information? And the truth of the matter is, it's hard for the individual practices and organizations to, and that's why our organization, the NSCHBC, is so important. Having a consultant that you can reach out to and you can ask for the most up-to-date information, or bring a consultant on hire a consultant to come in and provide you with that information. That is priceless. Think about all of the audits that are happening right now, all the overpayments that are being recouped, that letter, that additional documentation request letter that you received. Sometimes those things could all be mitigated if you had a great consultant on your team.
It's true. And I will have an article up on the NSCHBC at the beginning of January called the Telehealth Fact Sheet for your office. So you will have that. You can also find a version of it at the NAMIS site, namis.co. Christy and I both write for that site. So make sure you are finding this information from credible sources, because telehealth is here to stay. You just need to know in what capacity to make sure that you are appropriate for individual payers, Medicare, Medicaid, whatever you're taking. Okay, so Christine, I'm going to wrap it up. We'd like to thank you for being our guest today, and really appreciate
Thank you, Terry.
it. Thank you.
This has been a lot of fun. I always love chatting with you, and I really love chatting about telehealth, so I appreciate it.
Me too. To find Christine, you go to the NSCHBC website, click on Find a Consultant, and type in her first name. It's Christine with a C, and you will find her. Also, as a reminder, the nschbc.org website offers monthly free webinars on a variety of topics, as well as quarterly Medicare regulatory updates. Please go to the nschbc.org and click on the tab Upcoming Education. Our free webinar for next month, you definitely want to check that out. That is about some of the new business consultants and entities that have to have some new forms filled out for 2024, and it's important that your clients also know that. So that is it for us today, everyone. Make it a great day, a great rest of your month, and thank you for listening to the NSCHBC podcast. My name is Terry Fletcher.
Thank you for listening to the NSCHBC Edge podcast. Join us on the second Tuesday of each month as our consultants tackle the complexities of navigating the business of medicine. You can reach us on the web at nschbc.org, the National Society of Certified Healthcare Business Consultants.